Hello and good evening, I'm Melisa Idris.
And I'm Sharaad Kuttan.
You're watching Consider This, the show where we want you to consider and then reconsider what you know of the news of the day. Prime Minister Tan Sri Muhyiddin today launched the handbook for the National COVID-19 Immunization Program, which is said to provide an overview of the entire vaccination process, from registration to post-inoculation monitoring. Is this the well-designed vaccination plan that we've been waiting for? And are there questions that remain that are unaddressed in the plan? Joining us on the show tonight, we have Dr. Khor Swee Kheng. He's a consultant in public health policy and systems and one of the founders of the advocacy group, the Malaysian Health Coalition. Swee Kheng, welcome to the show. It's good to have you on the show with us tonight. I'm going to begin our conversation with something that may seem like an obvious question, but I think it's one that we need to ask. From a public health perspective, what are the objectives of a vaccination program? And what is it that we are hoping to achieve with this national vaccination program?
Melissa, it's good to be back. Well, there would be several objectives of a vaccination program. Perhaps I'll begin by saying that the objectives of a national vaccination program must be subservient, or they must serve the objectives of pandemic management overall. The vaccination program cannot be a standalone piece of the jigsaw puzzle. It must be a part of the jigsaw puzzle that helps us manage the pandemic. So any objectives of the vaccination program must really help achieve the national pandemic management strategy, which could be something like protect lives and achieve a balance between lives and livelihoods, and to reopen society as quickly as possible. So that's my first comment, to say that the objectives of the national vaccination program must serve the overall objectives of the national pandemic management itself. But if we zoom down into the vaccination program itself, Melissa, maybe we can look at a few objectives. The first one would be to get as many shots to as many people as quickly and as safely and as effectively as possible. Shot in arms of human beings, as many as possible, as quickly as possible, as safely as possible. That would be the operational objectives. But we would have a few other objectives that we can tack on to the operational objectives, which would be, number one, how can we use the existing infrastructure that we are building for COVID and deploy that to a multi-year COVID vaccination program, or deploy that to other vaccine-preventable diseases? Another secondary objective for the vaccination program could be for us to decide how can we improve equity within our health system. And the third objective, or secondary objective for the vaccination program, is how can we protect the marginalized communities in Malaysia. But again, Melissa, I go back to the overall objective that the national vaccination program must really serve the pandemic management of the country overall, and it cannot exist as a standalone component of the public health response.
Speaking, do you think it's likely that that the plan will focus on the immediacy of the pandemic and resolving that and getting those jabs into arms? That the larger questions that you raise of addressing equity and all that will in fact be left by the byway, just because no policy can be total, or at least for some policy is best narrowly cast, as it were.
Sharaad, this is an excellent point, because if we look at the landscape of COVID, it would be a landscape that's going to be multiple years. And this pandemic requires us to have a vaccination program that will be ultra long-term, because there is a possibility that we might need repeated vaccinations or booster doses. There will be variants already in the picture, for example, like the United Kingdom variant, the South Africa variant, or the Brazil variant, which at the moment we don't have a clear picture, but it looks like many of the vaccines will be protecting against this variant, which is very good news. But variants could come into the future, and if this pandemic will be a multi-year process, then we're definitely looking at the ultra long term as well, which then requires us to look at perhaps two different angles. One is the continuous procurement of vaccine supplies, and secondly, how can we manufacture more vaccines domestically in Malaysia so that we're not reliant on external supply?
Okay, there's a lot to digest there, so we're going to come back to those points. But I want to come back to what you said about the vaccination program cannot exist as a standalone from the larger public health measures in dealing with this pandemic. If that is in fact the case, then how are we going to measure the success of this plan? Do we look at it in how do you measure it? What are the KPIs to measure the success of this plan? Should it be seen in context of the wider pandemic management, including all the other public health measures that we currently now use, benchmarks like the daily caseload and etc.?
Melissa, this is a great question as well, and the KPIs, or the performance measurement for the success of the vaccination program, isn't described in the guidelines that were released by the Prime Minister today. And if we look at some corporate speak, or even frankly, any area of human activity, you can't manage what you can't measure. So we have to measure the success of the vaccination program, and let me propose several ways. The first one is coverage, meaning how many people have you vaccinated, and have they been equally spread out throughout the states and the districts? Are you vaccinating the 126,000 people that you said that you wanted to vaccinate? And coverage could be one set of KPIs for us to measure the success of the vaccination program. The second way we can measure the success of the vaccination program would be to look at the total number of cases. What I mean to say is that there are epidemiological or even public health criteria that we can look at as a second set of criteria, like the total number of cases, whether or not they've dropped, whether or not the severe cases have reduced, whether the number of people needing hospitalizations and admissions have been reduced, and there's a second set of criteria in terms of epidemiology, public health, and also health system utilization. The third set of criteria could be immunological, and this one requires a separate infrastructure. What happens when you get a vaccine is that you develop a certain level of antibodies within your body. Antibodies are what will help us fight the virus, and we may discover a bedside test for us to look at the titer or the amount of neutralizing antibodies, or whether, in a way, this helps you determine whether or not the vaccine has been truly effective in the population. There are some companies that are already developing bedside tests to look at the antibody titers, and if these tests were to be made available and available very freely, we would be able to measure, shall we say, the immunological response to the vaccination program. Melissa, these are three ways that we can measure the success of the vaccination program. For number one, the coverage; number two, epidemiological, public health, as well as health system utilization; and number three, the immunological criteria. There are perhaps many other criteria, but these are three initial ones for us to start the conversation.
Swee Kheng, just for a point of clarification, when I heard of bedside manner, but when you talk about bedside testing, do you mean that we can do this at home individually, or do you mean something else?
A combination of that, Sharaad. I think a test that you can do for your antibody titers at home by yourself without the presence of a healthcare professional is many, many years in the future. I'm thinking 3 to 5 years in the future. But in my desk research, I'm aware that several companies are already making laboratory tests and healthcare provider deployed tests. For example, you can deploy this in an emergency department without needing a laboratory, and that can give you a reasonable measure of antibodies present or not, antibodies against COVID, whether or not they're present or not in the body. And that's what I mean, Sharaad.
Okay. So can I just follow that up with what we see happening in other countries like Israel and the United Arab Emirates, who are leading in terms of the rollout of the vaccination program. I believe that Israel was already starting to produce reports that that the vaccination program was successful in bringing down infection rates. Now, is that something that we're seeing around the world globally? I mean, what can we expect to see in terms of a timeline of the effectiveness of the vaccine program? Will we see it in 6 months, 12 months, 18 months?
Sharaad, well, the data is still evolving, and I think scientists and public health specialists are collecting the data even as we speak. Let me provide us some additional pieces of data for us to understand, and I'm afraid I will not be able to give any predictions because we're still collecting the data. The first person who received a COVID vaccine as part of a massive vaccination program or mass vaccination program is in the United Kingdom on the 8th of December 2020. So that's about 2 months ago. In the last 2 months, approximately 180 million people have received one of 7 or 8 types of vaccines. There could be different types of vaccines. It could be the mRNA vaccine or the viral vector vaccine or the inactivated virus vaccines. In total, 180 million people around the world have received at least one dose of one of the 7 or 8 vaccines that have been approved. Of the 180, and by the way, 180 is about 2% of the world's population. So we vaccinated 2% of the world's population in the last 2 months or so. So that gives you a bit of an idea for how long the entire vaccination program would take. Israel, the data coming from Israel is actually coming from one of the insurance or the health managers over there. That have looked at data from about 600,000 people that have received the vaccine. And this population are generally the older population because Israel has decided to prioritize the elderly as their, say, first priority group. And it has shown up to a 94% reduction in infections and up to a 90-something% reduction as well in hospitalizations and severe disease. This is currently the information that's been released by essentially a health provider in Israel, and it hasn't really been published or peer-reviewed over there yet. To your question, Sharaad, of how quickly this effect has come, it's come as early as 3 to 4 weeks after the first dose. But then again, I would like to provide a caution over here that much more data is coming in even as we speak, and we'll be able to give a better idea perhaps 1, 2, or 3 months from today.
Swee Kheng, all this data that you talk about, it seems to me that, the vaccination plan is not just about administering those shots in the arms, but also looking at monitoring after inoculation and the effects of inoculation. Do we have the capacity for that? Is that kind of built into this vaccination plan?
It looks like it is built into our vaccination plan in Malaysia, Melissa. But let me divide the monitoring into, say, 3 parts or 3 types of monitoring. The first type of monitoring is the monitoring that's very immediate and very short-term to look for allergic reactions to the vaccine, and that takes place for about 30 minutes after the shot is given. That's one type of monitoring. But the second type of monitoring is that once you have received the vaccine, or even before you are receiving the vaccine, when you sign up for it, when you're scheduled for it, apparently you would go into a database of sorts that allows you to report any adverse events for many, many months after the vaccine has been deployed to you or administered to you the second dose. That's a second type of, say, monitoring, and that's probably a bit open-ended. And that monitoring gives you very easy channels for you to report adverse events so that Malaysia's government will be able to monitor the adverse events and provide you the necessary support if you need some. That's the second type of monitoring. But the third type of monitoring for long-term side effects and long-term safety profiles and effectiveness are done by the clinical trials themselves. For example, Pfizer right now, although they've recruited about 40,000 volunteers in their landmark trial that was published just a few months ago, for which they received approval in Malaysia and very many other countries, the participants in both groups, the placebo group and those who have received the vaccine, are continuing to be followed up for a period of 2 years after they've received the second dose. So, Melissa, we are following up very, very closely for potential side effects, not only immediately after the injection, but also in Malaysia for a period of many months after you receive the second dose, and also in the clinical trial setting.
Speaking of, we have just a quick question before we go to the break, which is that using multiple vaccines across the large territory that we are, will that make monitoring complicated and drawing inferences more complex because of the multiple vaccines?
It probably won't make the monitoring more complicated, Sharaad. There are a few characteristics that we need to be mindful of. The first one is that Malaysia's agreements at the moment, we have term sheet agreements. Term sheet agreements means that if the vaccines are approved by NPRA, or National Pharmaceutical Regulatory Agency, then we'll be able to bring the vaccines inside Malaysia. So of the 5 vaccines that Malaysia has at the moment, 4 of them are 2 doses, and 1 of them, CanSino Bio, the Chinese vaccine, is single dose. So 1 single dose and 4 double doses. That's one consideration for us to make sure that we don't, say, miss the doses, or we provide additional doses and so on and so forth. So that's one consideration in terms of the monitoring and the actual real-world monitoring that needs to take place. And the second characteristic of the vaccine for us to consider is that this vaccine probably should not mix and match. At the moment, this is the position of the Malaysian government and the position of very many countries around the world as well, except for the United Kingdom. In the United Kingdom, they are thinking about this mix and match strategy. For example, if you have vaccine A and vaccine B, and both of them require 2 doses, can you provide vaccine A in dose number 1 and vaccine B in dose number 2? And that's open to a lot of clinical trials at the moment and some real-world experience, but almost no country in the world is doing that, and not Malaysia as well. So we don't believe in a mix and match strategy as disclosed by the Prime Minister today. Those are the two considerations, Sharaad.
Okay, all right, Swee Kheng, we're going to go for a quick break, but after this, let's continue the conversation. We've got a lot to cover, everything from vaccine supply to vaccine priority. Who gets it first? Okay, we're going to talk about that all in a couple of minutes. Stay tuned to consider this.
Semua dah sedia? Jom! Walau apa pun gerakan.
Bila sentuh soal berita, tiada masa untuk tunggu. Kepada anda kami bawakan fakta, susulan dan kupasan yang terkini. Tiada drama dan tiada pengulangan. Usah tunggu lama-lama. AWANI 745 lebih awal dari biasa.
Kini berwajah baru.
Ini pula susulan khas pesawat Back Air di Kazakhstan. Pesawat berkenaan dilaporkan tergelincir 2 kali.
Notifikasi berita terkini dan navigasi mudah. Podcast dikemas kini dengan berita dan program.
Rebirth, Reformasi, Resistance and Hope.
Serta video tanpa had dengan scroll tanpa henti. Buat turun aplikasi baru Astro AWANI sekarang.
Gagalan Kerajaan Persekutuan tunai janji melaksanakan projek baik pulih sekolah daif turut diulas Menteri Muda Pendidikan dan Penyelidikan Teknologi Dr Anwar Rapai.
COVID-19, 2 lagi kes disyaki atau PUI direkodkan di Sarawak.
So hopefully kita akan mendapat kedudukan yang lebih baik di masa-masa akan datang.
Udang geragau atau bubuk dalam bahasa tempatan terkenal sebagai bahan utama dalam pembuatan belacan atau cencaluk.
Amanah di tangan kita. Adat, budaya dan semangat menjadi kesinambungan perpaduan tanah air yang tercinta. Berteraskan adab yang terpahat di jiwa.
Hi, thanks so much for staying with Sharaad and I on Consider This. Let's continue our conversation with Public Health Policy and Systems Consultant Dr Khor Swee Kheng. Swee Kheng, you've had some time to look through this handbook for the National COVID-19 Immunisation Plan. I have to ask you, have you identified any gaps in the plan yet?
Well, Melisa, it's a good plan. It's a good plan. A little, I would say, underwhelming because a lot of it has been released before in various stages by Minister Khairi himself and a few other people in the government. So I might begin there. But there seems to be a few areas that we've missed out some detail. And I'm certain that there are operational details somewhere inside government documents, which at some point must be given out to the public so that we can scrutinize this and add on to it in a truly whole-of-society response. Here are some of those potentially missing points. Number 1, how will the Ministry of Science, Technology and Innovation interact with the Ministry of Health, given that the coordinating Minister for Vaccination is not the Minister of Health and will need to coordinate with... I'm sorry, we may have lost video, but we'll continue on the conversation. We'll need to continue with the vaccination program using the apparatus and the machinery of the Ministry of Health. So that appears to be one missing element. The second missing element would be what to do with vaccine liability, as in what you, in the very unlikely and very rare event that there is a side effect from the vaccine, and the vaccine in real life has been very, shall we say, safe in terms of its deployment, what do we do with vaccine liability? And thirdly, what do we do with the essential workers? So there appears to be an asterisk in the first phase of the vaccination program that talks about essential workers, and the definition of essential workers is still left up to question. So that appears to be a bit of a loophole that anybody can go up and lobby the government to be included as a frontliner of some sort. And that could we could find ourselves into a position where we are, say, providing the vaccines perhaps unnecessarily to people who might not need it. These are the three loopholes, shall we say, that needs to be clarified by the government in terms of the vaccine rollout.
Speaking, if we could just focus on the last point you made about the essential workers, because I think that's something that perhaps a lot of us are concerned about, whether we will be in that first priority group or not. And what's your sense of it? I mean, you know, between workers on an assembly line producing gloves for the world and other, you know, and PPE for the world versus parliamentarians versus, seafarers who are essential to global trade and apparently are kind of in a difficult position now because the need for vaccination and immunization certificates.
And don't forget teachers. You know that there's been a call to include teachers as part of the priority group as well.
Sharaad and Melisa, these are excellent examples of frontliners, and these are essential workers as well. Teachers, retailers, seamen and seawomen, people who are the media, for example. This, I guess my first point is that very many functions are essential to the conduct and the operations of any human society, including Malaysia's. And I'll begin by saying that we owe all these people as much protection as we can provide to them. The second point that I'll make, right, would be more realistic, less idealistic. Idealistically, we will provide everybody with as much vaccines, as much protection, and as many vaccine doses as we can find. But real-world considerations for supply constraints will often have to come in. In Malaysia's first batch of vaccines, instead of having 148,000 doses, right now we've got about 310,000 doses. This is testament to the negotiating skills of the government in procuring more vaccines than Pfizer's, Moderna's and AstraZeneca's are able to provide. So kudos to the government. But until and unless we get enough doses for 1 time, 2 times, 5 times our population, we will always have a problem of scarcity. And this is my third and final comment. How do we deal with that scarcity? Given that even if Malaysia can afford to pay a high premium for a lot of vaccines, we might not be able to have these supplies come to us all at once. So how do we manage the problem of scarcity? We manage it perhaps in 2 ways. Number one, we need a system, a framework of sorts that Malaysians in a social contract can agree with, that these are the true priorities, because if everyone's a priority, then no one really is a priority. Now, to build that framework, which isn't present in the guidebook that was released by the Prime Minister today, this framework should consider a few factors. The first factor would be the actual risk of these people contracting COVID, and we can look at the exposure risk and measure the number of clusters and cases in that particular demographic, and that gives us an objective basis to say that these group of people are truly at risk. Number two, there should be some criteria for essentiality, meaning how do you actually define what is essential? We could look at the National Security Council Act definition of what is essential. We could maybe have a bit of a survey of some sort for us to define, for society to help define what is essential. And the third one would be the vaccine characteristics, as in maybe this particular vaccine will be more easily deployed in say rural areas or to a particular age group or to a particular demographic. And these are 3 sets of criteria that can help us decide the criticality of it and the essentiality of the services, so that we can make decisions during a period of scarcity. And I do predict that there will be a period of scarcity for at least the next 1 year in Malaysia. We might have a framework ready to go, but I think our supplies could be a bit of a constraint.
Can I ask you about the, identifying who is essential and to kind of follow up on that? Because if we take a look at Indonesia's vaccination strategy, they've got a bit of an unorthodox strategy. They've chosen to immunize young workers before the aging population. So vaccinate the young first. What do you make of that?
Well, Indonesia's stance is, shall we say, an outlier stance. Very many other countries are choosing to prioritize either health workers or the elderly first. the World Health Organization does state that the elderly and the health professionals and the health workforce, rather, should be the first priority. But Indonesia has chosen to go this particular route, and I can see why they do so. They do so because they believe that they make the political assessment and the social assessment that the young people and the economically active age groups are those who are more deserving of protection. And it's difficult for us to say that Indonesia is right or wrong because there are multiple correct answers over here. So that's, shall we say, my first assessment of the Indonesian situation. But Melisa and Sharaad, if we look at other countries, they have maybe they've done two ways to adapted two measures in order to try to avoid making this very difficult decision of who to prioritize. The first strategy that they have is to break up phase 1 into multiple little pockets. For example, the state of California in the US, they have got a very nuanced phasing system. So there's phase 1, 2, 3, of course, just like Malaysia. But phase 1 has phase 1A, 1B, and 1C. And in phase 1A, 1B, and 1C, there is tier 1, tier 2, and tier 3, including people who might not ordinarily qualify to become a frontliner in very many countries. Nonetheless, they're in a position where they are splitting up their tiers and phases into very small buckets so that they can avoid a difficult conversation and avoid a difficult decision of making a priority for a particular group.
Speaking, if I could ask you about the dual nature of vaccines. One is that it protects the individual from infection, but it also stops you from transmitting it. And so in the Indonesian case, are we looking at a strategy that is focused on the transmission dimension of vaccination, meaning you go to the spreaders and you try to stop them, the most economically active, and try to stop them from spreading the disease?
Sure, that is one possibility that the Indonesian government has looked at the epidemiological data, and perhaps, and frankly, I'm not an expert on Indonesia, nor have I looked at the epidemiological data of Indonesia, but it appears to me also, based on limited information, that there is a lot of community transmission in Indonesia, and the disease and epidemiological profiles are reasonably similar to Malaysia's. So I would like to make that comment and then set it aside very quickly to move on to the second comment about the vaccine itself. In general terms, the first generation vaccines that we have found, including the ones deployed in Indonesia by Sinovac, are good at preventing disease and severe disease. But there is very little evidence that they can actually prevent transmission. So we might have to wait for a second generation vaccine in order to truly prevent transmission. But that being said, whenever you prevent severe disease and a total number of cases, in effect, you are reducing the amount of community transmission happening in the country. It's a very grey area and a very fine line between from severe disease to transmission. And I think it's very easy to go back and forth around this continuum.
Right. Well, in the couple minutes that we have left speaking, I wanted to touch on vaccine supply. So under the immunization plan, we've secured vaccines from 5 companies, I believe, and Pfizer's the only one that's gotten the National Pharmaceutical Regulatory Agency approval here. What about the others? Because, you know, we've got procurement contracts with them, but they've not yet been approved by the NPRA. How does that work?
It's a bit of a chicken and egg situation right now, Melissa. The chicken and egg situation is as follows. We as in companies and the government, for example, Pharmaniaga and the government of Malaysia, we signed what are essentially called term sheet agreements. Term sheet agreement means that you agree a little bit of the principles, but it's not activated until to become a full-fledged distribution agreement until you get NPRA approval. So on one hand, we signed the agreements and we want NPRA to hopefully review the data and provide their best available decisions. And on the other, we can't get the supply, we can't activate the contract until we get NPRA approval. That's a bit of a chicken and egg situation. However, what we're trying to do to resolve the situation would be for NPRA to adopt a conditional registration during disaster pathway, which was approved on the 15th of December last year, which is great because with that pathway, we can provide conditional registration to the vaccines, and that's a faster pathway than the usual pathway to get full registration. That's one way that we try to overcome this. But number two, we've also tried to overcome this by getting as many data and as many dossiers as possible, as quickly as possible.
Okay. Swee Kheng, thank you so much for joining us on the show tonight. Unfortunately, that's all the time we have for you on this episode of Consider This. I'm Melisa Idris.
And I'm Sharaad Kuttan.
Thank you so much
Signing
for
off for the
watching,
evening.
and good night. Good night.